pleasure to be here, and really a pleasure to talk about a project that I'm really passionate about, and really something that I think will be transformative of the way we actually practice emergency care across our state. You can see there's lots of ways to get in touch with me. Certainly, if you're on Twitter, please tweet. I will respond. And sorry, I'll get a little closer. And you'll probably hear some parallels to actually what Dr. Alpern was talking about with her project earlier this morning. So I'm actually going to start with the acknowledgement slides because this is a very deep and long bench of people involved in this project. This is not successful without tremendous amounts of time and effort on a number of people's investment. Certainly in the audience, we've got a number of our coordinating center staff here. Dr. Michelle Nypaver is co-director of the project as well. And you can see there are a number of institutions that are heavily involved in this work that I've listed here. And you'll hear about some of their stories through the talk here. This is funded by Blue Cross Blue Shield of Michigan. I'll talk about why they have an interest in this work. That's one of my disclosures here. So I'm just going to sort of highlight two things: why MEDIC and what is MEDIC. And there's lots of ways to sort of begin this conversation. But I think this is probably the easiest framing of it. So MEDIC is really a strategic bet. And it hinges on a couple conditions. One, that there is opportunity, that there are gaps in the way that we practice our care between where evidence suggests we should be and what we are actually doing. That we can find alignment between the interests of a payer and a set of providers, hospitals, and emergency physicians in particular, and that there's a community that will be responsive to the type of project that we can put into place here. And I'll sort of talk through each of these individually. First, let's talk about opportunity. And I'd be really curious to hear about from all of you, who work daily in the ED, where you think those opportunities are, because we know they exist. We know we see them every day in our care decisions. But at the end of the day, these are the kinds of things that we use as we choose our quality initiatives. There's got to be evidence. It's got to be fair, and by that I mean sort of in the locus of control of our decisions. It's got to discriminate between sort of what are low and high performance, and it's got to be feasible. At the end of the day, we have to be able to collect the data, we have to measure it in a meaningful way. So there's lots of ways to look for that. Certainly go to the medical literature. These are a few of the studies that we rely on to form the conceptual underpinnings of our quality initiatives. You could look to authoritative bodies. Many of our quality initiatives line up with the Choosing Wisely recommendations from AEP and ACEP. So while I'd be interested in knowing yours, these are the ones that we started with within our project. What we thought were opportunity targets. We are looking at the use of head CTs for minor head injuries where there is great evidence in both adults, where we use the Canadian head CT rule as our standard, and children with the PCARN rule. We measure use of chest x-rays in common pediatric respiratory conditions. We are looking at use of CT scans for suspected pulmonary embolism evaluations. And then we have a programmatic quality initiative, which we call PATH, where we are facilitating the development of alternative care pathways away from the hospital, either observation or discharge. And we have a poster about that at our, if you want to come by and we can talk a little bit more about that in detail. We also are turning on some new quality initiatives within the last year. These are early in development. We have a initiative where we want people to measure consistently weight on pediatric ED visits, where we feel like this is an important patient safety and harm reduction strategy. And then we're looking at use of head CT scans in uncomplicated syncope patients and adults and headaches in children. These are Choosing Wisely recommendations that are out there. So let's talk about alignment. Why in the world would a dominant payer in our state have any interest in spending a lot of money in supporting this project. And I think there's probably a number of reasons, but I think, these are three of the major ones. And they recognize that, they don't know, like we do, where those opportunities lie. We know in our daily work where we fall short of where evidence is. They don't know how to measure in a way that is meaningful or feasible, like a community of emergency physicians. And they don't have the engagement. They don't have the connections to emergency physicians across the state to actually dig in and change practice. So let's talk about community. So, within the strict bounds of the project, we have clinical champions that are our liaisons between us and the Corning Center and each of our sites. We have data distractors that are funded by the project, embedded at all the sites that are giving us high-quality data with some clinical granularity that we use. And we have administrators that support this work too. I would say that we are in the chasm phase of this project where we have some folks that are early adopters into the vision, but a lot of our work is convincing others that weren't so readily on board to buying into the project. And then really, like at the end of the day, you are our community too, even though you may not really know that yet. For all those that work in the ED, it's the sum of all your care decisions that ultimately get into our measurement in our registry, and I'll talk a little bit about that. So let's talk about sort of what is MEDIC. And there's, again, sort of lots of ways to talk about this, but I think in the day it's a nudge, or maybe a shove, depending on sort of how you interpret that. And it's really to catalyze practice change, to accelerate the knowledge translation between evidence to changing practice, which is really hard to do. That's sort of that blue afferent pathway. But I think what is unique about MEDIC and other learning collaboratives is there is also this efferent wing, where we have 15 types of experiments going on at all our individual sites around quality improvement, and we try to capture the learning that is going on there and being able to disseminate that across the network in a way that allows people to better engage on practice change more easily and sort of lower that activation energy required to do that. That's a learning collaborative. We fall into a family of these projects that Blue Cross sponsors called Value Partnerships. These are across multiple specialty areas. We are one of the newest within this family. And this is what our current network looks like. We have 15 sites and 2 that we are onboarding this year. They span the state. We have a broad mix of different practice settings within them in our specialty. And we represent about 1.25 million ED encounters annually, which is about 30% of all the ED visits within the state. At the heart of MEDIC is a clinical registry. And we have spent inordinate amounts of time and energy in overcoming the technical requirements of getting automated data flow from all of our sites, enhanced with clinical chart abstraction for certain of our cases. This is sort of the state of the registry, about 1.5 months, 1.5 years worth of data. We have about 1.5 million ED encounters. And then there's sort of various buckets of case counts depending on the quality initiative that we're looking at. The one in orange are the newest ones, so we don't have a lot of experience yet to sort of understand where our quality measure is going to settle out. But if you just sort of think about how we can, if we were to sort of maximize the practice change and the quality improvement across the historical data in this registry, we would probably have avoided about 5,000 head CT scans, 4,000 PECT scans, and 2,300 or so chest x-rays, again, in sort of the historical capture of our data. And that's what we're trying to change. So this is how MEDIC stands currently in our Baseline performance, this is up through the end of December of last year. We have set performance targets. Many of these are what I would call aspirational still. They are stretch targets, but this is where we want to achieve across all our sites. What's in red is our current performance. The black arrows are the direction that we need to go. And you can see, some places we're close and some places we certainly are not. In the far column is our site ranges. So you can see that some sites are, again, sort of closer or farther to where we want to achieve. And then finally, the hardest part of this project, I think, is the knowledge translation part. To get local with our sites, equip them with the quality improvement incentives and tools to be able to change practice is hard. This is just sort of one of our tools that we use in the coordinating center. This is called a SPC chart, or statistical process control chart, where we actually try to line up a site's intervention with the actual change in their measurement. That's that light blue trend line that we're trying to change and move upwards in this particular case, which is the adult head injury measure, where we're trying to reach that green target line. So as I said, at the end of the day, you are actually all in this project. And we measure both at the site level and at the provider level. So all those in this room who are attending are actually able to access your own individualized report from our website in a blinded fashion relative to your peers. Residents and PAs, your work is embedded under the attending, that's how we attribute in this case. And so you can actually go on our website and request access, and we will give it to you, and you will be able to see your own performance. That's it.